Today our topic is hepatic failure and portal hypertension. Hepatic failure কাকে বলে? It is characterized by massive necrosis of liver cell. Acute hepatic failure. Acute hepatic failure is characterized by massive necrosis of liver cell, and advanced chronic liver disease is called chronic hepatic failure. The most severe form of liver disease is liver failure, which may be acute or chronic, following years of insidious progressive liver injury. Acute liver failure. Acute liver failure is defined as an acute liver illness associated with encephalopathy and coagulopathy that occurs within 26 weeks of the initial liver injury. So 26 weeks is the cutoff for acute and chronic. Within 26 weeks, we will call acute liver failure. After 26 weeks, we will call chronic liver failure. But usually, syndrome manifests within 8 weeks of injury, and many patients progress to coma within only a week. Very rapid onset acute liver failure is most often induced by drugs or toxins and is typically result of massive hepatic necrosis. This also called fulminant liver failure in the past, but now we call it acute liver failure. Etiology: acute viral hepatitis. Acute viral hepatitis, which virus? Hepatitis A and hepatitis E. A and E for acute. Other causes are hepatotoxic drug reaction, carbon tetrachloride poisoning, acute alcoholic hepatitis, mushroom poisoning, pregnancy complicated with eclampsia. Clinical features: acute liver failure manifests with nausea, vomiting, jaundice, followed by life-threatening encephalopathy and coagulation defect. Typically, serum liver transaminases are markedly elevated. The liver is initially enlarged due to hepatocyte swelling, inflammatory infiltrate, and edema. As parenchyma is destroyed, liver shrinks dramatically. First, liver will enlarge, then liver will shrink. Cholestasis occurs due to alteration of bile formation and flow, leading to retention of bilirubin and other solute normally eliminated in bile, and yellowish discoloration of skin and sclera, that is called jaundice and icterus, and life-threatening bacterial infection. Then hepatic encephalopathy, ascarixis. Ascarixis means non-rhythmic rapid extension flexion movement of the head and extremities. Then coagulopathy. We all know liver produces some coagulation factor or clotting factor like factor 2, 5, 7, 9, 10 and 11, 12. So if hepatic failure is occurred, then coagulopathy will be occurred. Thus with liver failure, factor deficiency and coagulopathy develop. Then portal hypertension. Portal hypertension arises when there is diminished flow through the portal venous system, which may occur because of obstruction at the prehepatic, intrahepatic, and posthepatic. Although it can occur in acute liver failure, portal hypertension is more commonly seen with chronic liver failure. Then hepatorenal syndrome. Hepatorenal syndrome means liver and kidney both are affected, and due to kidney is affected, so drop in urine output and increasing level of urea and creatinine in blood. That is called hepatorenal syndrome. Now morphology. In the acute liver failure morphology, massive hepatic necrosis, parenchymal loss, and affected liver will be small and shrunken. Toxic injury such as acetoaminophene overdose usually take place within hours to days, too brief a period to allow scar formation or regeneration. Acute viral infection may cause failure over weeks to few months. Regeneration is often evident along with scarring. This is the cross-section of the liver. You can see liver is small, bile-state, soft, congested. And these all are necrosis, necrotic part of the liver. And it is the microscopic picture of that liver. This part is necrotic part. This is necrosis. This is necrosis, and this is the normal hepatocyte. These all are normal hepatocyte. And this part is necrotic part. Now complications. Encephalopathy and cerebral edema, hypoglycemia, metabolic acidosis, renal failure, and at last, multi-organ failure will occur. Now, chronic liver failure and cirrhosis. Liver failure in chronic liver disease is most often associated with advanced fibrosis or cirrhosis, a condition marked by diffuse remodeling of the liver into parenchymal nodules, surrounded by fibrous bands and variable degree of vascular shunting. So, chronic liver failure is characterized by diffuse remodeling of the liver into parenchymal nodules surrounded by fibrous band and variable degree of vascular shunting, or it is also called portosystemic shunting. The leading cause of chronic liver failure, chronic hepatitis B and chronic hepatitis C. For acute liver failure, it was hepatitis A and E. And for chronic liver failure, mainly A and E for acute hepatitis. And for chronic liver failure, chronic hepatitis B and C. Along with that, non-alcoholic fatty liver disease, alcoholic liver disease. Although cirrhosis and chronic liver failure are often associated, they are not synonymous. That means all cases of cirrhosis is not due to chronic liver failure, and all chronic liver failure will end in cirrhosis. That is not done. Now, clinical features. About 40% of individuals with cirrhosis are asymptomatic until the most advanced stage of disease. When symptomatic, they present with non-specific manifestation like anorexia, weight loss, weakness. In advanced disease, symptoms and signs of liver failure. Common cause of death are hepatic encephalopathy, bleeding from esophageal varices, bacterial infections resulting from damage to the gut mucosal barrier and Kupffer cell dysfunction, and hepatocellular carcinoma. In addition to jaundice, encephalopathy, and coagulopathy, chronic liver failure is associated with several other significant features. These are pruritus, means itching, impaired estrogen metabolism, leads to hyperestrogenemia, which has several effects, and palmar erythema due to reflection of local vasodilatation, and spider angiomas of the skin. In males, hyperestrogenemia may also produce hypothyroidism and gynecomastia. Now, it is a summary. It is a mnemonic for acute liver failure, A, B, C, D, E, F. A for acetoaminophene, hepatitis A, autoimmune hepatitis. B for hepatitis B, C for hepatitis C, G for drugs, toxin, hepatitis G, E for hepatitis E, and along with some other cause, Wilson disease, Budd-Chiari syndrome, lymphoma, carcinoma. F for fatty change of the microvesicular type. Serious and sometimes fatal sequelae of liver failure include coagulopathy, encephalopathy, portal hypertension, bleeding, esophageal varices, hepatorenal syndrome. Now, second part, that is portal hypertension. Portal hypertension means increase in pressure in the portal system usually follows obstruction to the portal blood flow anywhere along its course. And portal veins have no valves, and thus obstruction anywhere in the portal system raise pressure in all the veins proximal to the obstruction. However, unless proved otherwise, portal hypertension means obstruction to the portal blood flow by cirrhosis of liver. So main cause is cirrhosis of liver, if not proved otherwise. Normal portal venous pressure 10 to 15 millimeter of saline water. And when we will call it portal hypertension, when it is more than 30 millimeter of saline. Now etiology, we can divide it pre-hepatic, intrahepatic and post-hepatic. Now, there are lots of causes of portal hypertension. Among these, major pre-hepatic conditions are obstructive thrombosis, narrowing of the portal vein before it ramifies within the liver, or massive splenomegaly with increased splenic vein blood flow. Main post-hepatic cause, severe right-sided heart failure, constrictive pericarditis, and hepatic vein outflow obstruction. And dominant intrahepatic cause is cirrhosis of liver, accounting for most cases of portal hypertension. So, commonest cause of portal hypertension is cirrhosis. Now, pathogenesis. Why portal hypertension is occurring? Involve resistance to portal flow at the level of sinusoid. Sinusoid is present inside the liver. And then increased portal flow caused by hyperdynamic circulation. The increased resistance to portal flow at the level of the sinusoid is caused by contraction of vascular smooth muscle cell and myofibroblast. This is the main cause of portal hypertension. Increased resistance to portal flow at the level of the sinusoid is caused by contraction of vascular smooth muscle and myofibroblast. And disruption of blood flow by scarring and the formation of parenchymal nodules. Then alteration in sinusoidal endothelial cell that contribute to the intrahepatic vasoconstriction associated with portal hypertension include a decrease in nitric oxide production and increase endothelin 1, angiotensinogen and eicosanoids. Normally nitric oxide কি করে না nitric oxide করে vasodilatation করে and endothelin 1, angiotensinogen and eicosanoid vasoconstriction করে. So nitric oxide decrease করলে পরে ওটা ভেসো আর endothelin 1 angiotensin increase করলে পরে there will be more vasoconstriction will occur. So intrahepatic vasoconstriction will occur. And then sinusoidal remodeling and anastomosis between the arterial and portal system in the fibrous septa contribute to portal hypertension by imposing arterial pressure on the low pressure portal venous system. And there is another theory or another major factor of portal hypertension is increasing portal venous flow resulting from a hyperdynamic circulation. This is caused by arterial vasodilation. This is caused by arterial vasodilation. The increase in splanchnic arterial blood flow in turn leads to increased venous efflux into the portal venous system. While various mediators such as prostacyclin, TNF have been implicated in the causation of the splanchnic arterial vasodilation, AO means nitric oxide has emerged as the most significant one because nitric oxide is a product that causes vasodilation. Now, the four major consequences of portal hypertension: hepatic encephalopathy, ascites, formation of portosystemic venous shunt that is called varices, and congestive splenomegaly. So these are the major clinical consequences of portal hypertension. Sinusoid present inside the liver. Okay. So now ascites. Ascites is the accumulation of excessive volume of fluid within the peritoneal cavity. It frequently accompanies cirrhosis and other diffuse liver disease. The development of ascites is associated with hemodilution, edema, and decreased urinary output. Ascitic fluid is generally transuded with specific gravity 1.010, protein content below 3 gram per dl. It may contain few mesothelial cells and mononuclear cells. Presence of neutrophils is suggestive of secondary infection, and red blood cells in ascitic fluid point to disseminated intra-abdominal cancer. However, some cases of ascites may develop serious complication of spontaneous bacterial peritonitis characterized by spontaneous infection of the ascitic fluid without any intra-abdominal infection. Now, varices. Varices means collateral channels or portosystemic shunt. These are called varices. This is esophageal varices. It is also varices, hemorrhages. As a result of rising portal venous pressure and the obstruction in the portal circulation, within or outside the liver, the blood tends to bypass the liver and return to the heart by development of portosystemic collateral channels. These varices develop at the site where systemic and portal circulation have common capillary bed. Principal site of formation of varices: one is esophageal varices. The development of esophagogastric varices, which is frequently manifested by massive hematemesis, is the most important consequence of portal hypertension. Then hemorrhage. Hemorrhage development of collateral between the superior, middle, and inferior hemorrhagal vein resulting in hemorrhage is another common accompaniment. Bleeding from hemorrhage is usually not as serious complication as hematemesis from esophageal varices. Hematemesis is much more serious complication than hemorrhage because blood loss will be much more in hematemesis that is developed from esophageal varices. Then third is caput medusa. Anastomosis between the portal and systemic veins may develop between the hilum of the liver and the umbilicus along the para-umbilical plexus of veins, resulting in abdominal wall collaterals. These appear as dilated subcutaneous vein radiating from the umbilicus and the term as caput medusa. Caput medusa occur around the umbilicus. Now, splenomegaly. The enlargement of spleen in prolonged portal hypertension is called congestive splenomegaly. The spleen may weigh 500 to 1000 gram and is easily palpable. The spleen is larger in young people and in macronodular cirrhosis than in micronodular cirrhosis. Macronodular cirrhosis is more common here. Now, hepatic encephalopathy. Poor to systemic venous shunting may result in a complex metabolic and organic syndrome of the brain characterized by disturbed consciousness, neurological sign, and flapping tremor. Why hepatic encephalopathy is occurring? Due to ammonia. Ammonia is the main factor which causes this hepatic encephalopathy. Because normally what happens? Normally ammonia by formation of ammonia occur by gut flora in our intestine. And that ammonia normally secreted from our body by urea cycle. From ammonia to urea by urea cycle. But in case of liver failure, this mechanism not happen, and ammonia is present inside our body and it mixes with the blood and cross the blood-brain barrier. So hepatic encephalopathy occurs due to accumulation of ammonia. Hepatic encephalopathy is particularly associated with advanced hepatocellular disease such as cirrhosis. Now complications. Variceal bleeding, congestive gastropathy, hypersplenism, ascites, iron deficiency anemia, renal failure, hepatic encephalopathy. Now it is the summary of why portal hypertension occurring in our body. Increased portal vasculature resistance leads to a gradual reduction in the flow of the portal blood to the liver. That's why the first mechanism is increased portal vasculature resistance. As the portal vasculature resistance is increasing, that's why simultaneously development of collateral vessel, allowing portal blood to bypass the liver and enter systemic circulation directly. That's why portosystemic shunt is developing. Because of portal blood bypass the liver, normally portal blood enters the liver. But due to formation of collateral vessel, why formation of collateral vessel is occurring? Due to increased portal vasculature resistance. So, as portal vasculature resistance is occurring, so collateral vessels are occurring. Then, for that allowing portal blood to bypass the liver and enter the systemic circulation directly. That's why portosystemic shunt is occurring. Portosystemic shunting occurs particularly in the gastrointestinal tract and especially the distal esophagus, stomach, and rectum in the anterior abdominal wall. বুঝতে পেরেছি কেন portosystemic shunt তৈরি হচ্ছে, ফর্মেশন হচ্ছে? Because starts from increase in portal vasculature resistance formation. Then simultaneous development of collateral vessel. Then allowing portal blood to bypass the liver and enter the systemic circulation directly. Then the portosystemic shunting occurs at near esophagus, that is called esophageal varices, and hemorrhoids, and around the umbilicus, that is called caput medusa. These are the complications of portal hypertension. Hepatic encephalopathy occurring in the brain, esophageal varices occurring around the esophagus, and congestive splenomegaly, ascites, and hemorrhoids. And cirrhosis present inside the liver.